Swayam Prabha. Digital India. Educated India.
So good day, and once again welcome back to the sessions on gross anatomy. So today we'll be talking about the arch of aorta. This is Dr. Mauna Subbaramaya, working as Associate Professor at Keppegowda Institute of Medical Sciences, Bengaluru. So let's begin the session with a historical vignette. So there was this person by name Sir William Silver Oliver. He was an English military surgeon practicing in India in the British era. So in about 1878, he came up with a sign called as the Oliver sign or the tracheal tuck sign. So this was first described in 1878 by this military surgeon. And what is the sign all about? How do you elicit this sign? When do you say the sign is positive, and what does it suggest? So how do you elicit this sign? You ask a person to stand erect with an extended neck. You grasp his cricoid cartilage with the index and your thumb finger with a slight upward thrust or pressure. So if the sign is positive, then there will be a downward descent of the trachea. You can feel a tug movement on every ventricular systole. So every time the ventricle contracts, you find this descent of the trachea taking place. So this is when you say the Oliver sign is positive. So there is a downward movement of the trachea on every ventricular systole. So when does this happen? So it's usually a case of aortic aneurysm. Now the relation between the arch of aorta and the trachea and the left bronchus is the anatomical basis for the elicitation of the sign or the sign becoming positive. Now a similar sign known as the Cardarelli sign was also described along the same era, and people use it synonymously, but actually there is a slight difference between the two. Now in Cardarelli sign there is an abnormal pulsation which is felt, whereas in Oliver sign you can actually make out the descent of the trachea. So there is a slight difference between these two signs. So with this historical note, let's proceed to the core of the lecture. So the objectives of today's lecture are as follows. First, we will be looking at the location. Then we'll be looking at the course of the arch of aorta, the important relations, the branches of the arch of aorta, the development, structure, and clinical aspects. So where is the arch of aorta located? So it is situated in the superior mediasternum, just behind the lower half of the manubrium sternum. So if you were to consider this as the manubrium sternum, the lower half of the manubrium sternum is related to the arch of aorta. So what is its extent? So the arch of aorta begins at the right sternocostal junction, and here the diameter is around 3 centimeters, and it starts as a continuation of the ascending aorta. And the arch proceeds backwards and it ends at the left sternocostal junction, and here the diameter is around 2 centimeters. So as the arch is proceeding backwards, it is narrowing down. And the arch begins anteriorly and it ends posteriorly, but the beginning and the ending is almost at the same level. Okay. So what is the course of this arch? So initially the arch courses superiorly, posteriorly, and to the left, and then finally inferiorly. So it is anterior to these two structures, that is the pulmonary artery and the bifurcation of the trachea. It then ascends upwards on the left side of the trachea and esophagus. And over this region, as the arch proceeds backwards, it is resting over the root of the left lung. and then it proceeds onto the posterior aspect on the roof of the left lung, and then descends inferiorly as a continuation of the descending thoracic aorta. And this ends at the T4 vertebra. So, what is the importance of this location? So, based on this location, we are able to picturize the arch of aorta in various X-rays, CTs and MRIs. So, when we take a photograph of the chest PA, so that is a posterior anterior view of the chest, the arch of aorta is seen as a white shadow just above the left border of the heart. So, this is the distal portion of the arch of aorta, which is seen adjacent to the sternal angle. So, the place where the arch ends, that is seen as this white shadow region, and this region is referred to as the aortic knuckle or the aortic knob. Now, this becomes a little prominent as age increases, and also if it is unduly enlarged, or if you find a huge shadow there, then it can suggest any pathology of the aorta itself. So, this is a screenshot of a CT aortogram showing the lateral view of the chest, and here you can make out the course of the arch of aorta as it proceeds backwards, and you can also make out the 3 branches of the arch of aorta. And this region just beneath the arch, that is the space between the arch and the tracheal bifurcation, is referred to as the aortic window, and if this area is compressed, then again it will suggest some anomaly in either the arch of aorta or in the trachea. So, that region is referred to as the aortic window region. So, this is the lateral view of the arch of aorta. And based on the location itself, we can determine the approach to the arch of aorta as well. So, arch of aorta was initially approached by open thoracotomy, which of late has been avoided for many reasons, and recently the endovascular procedures have taken over. So, in case it has to be approached through open thoracotomy, then the sternum has to be lifted and the arch of aorta can be reached. So, next let us move on to the relations. So, these relations can be grouped as relations which are present anterior and to the left, posterior and to the right, superior relations and inferior relations. So, the reason why we are choosing the anterior and left is because the arch is coursing backwards and to the left. So, these are the important relations on the anterior aspect and slightly to the left of the arch of aorta. So, to begin with, we have the left lung and pleura. Next, we have the left phrenic nerve. This side we have the left vagus nerve, the left cardiac nerves and the left superior intercostal vein. So, these are the structures which are related anteriorly. So, to repeat, you have 3 nerves, that is the phrenic nerve, the vagus nerve and the left cardiac nerves. These are branches coming from the left sympathetic trunk, and you have one vein, that is the left superior intercostal vein, and the left lung and pleura form the anterior and left relations. Moving on to the posterior aspect and slightly to the right, these are the following structures which are related to the arch of aorta. They include 2 tubes, that is the trachea and the esophagus. We also have a lymphatic channel, that is the thoracic duct, and also the thoracic vertebrae, which is lying more posteriorly to the arch. In addition, we find a nerve, that is the left recurrent laryngeal nerve, as it goes back. So, these are the 5 structures which are related posteriorly and to the right. In addition to these, we have the situation of the deep cardiac plexus just posterior to this arch of aorta. Now, the deep cardiac plexus is lying in front of the trachea and behind the arch of aorta. So, this is being formed by branches which are coming from both the sympathetic trunks, that is the superior, middle and inferior cervical ganglion, and also the branches which are coming from vagus, both the vagus, except those which are going to the superficial cardiac plexus, that is a branch which is coming from the left superior cervical ganglion and one branch which is coming from the left vagus. So, apart from these two, all other branches from both the sympathetic trunks and the vagus reach the deep cardiac plexus, and this is situated on the posterior aspect of this arch of aorta. So, to repeat, on the posterior aspect there are two tubes, trachea, esophagus, the lymphatic channel, that is the thoracic duct, the thoracic vertebrae, the left recurrent laryngeal nerve and the situation of the deep cardiac plexus, which cannot be shown in this particular picture. Next, moving on to the inferior relations. So, inferiorly we have the bifurcation of the pulmonary trunk, the left pulmonary artery, and the structure which is shown in the dotted line is the ligamentum arteriosum. So, this is present since birth. It was previously the ductus arteriosus, which gets fibrosed at birth to form the ligamentum arteriosum. It is a connection between the left pulmonary artery and the arch of aorta. And to the right of this ligamentum arteriosum, we find the superficial cardiac plexus, and it receives branches from the left vagus and from the superior cervical ganglion. So, there are the superior cardiac branch is coming from the superior cervical ganglion and the inferior cardiac branch is coming from the left vagus. So, these two branches reach this superficial cardiac plexus. Rest of the branches will go to the deep cardiac plexus, which is situated behind the arch of aorta. And the last relation which is present on the inferior aspect is the left recurrent laryngeal nerve, which is onto the left side of the ligamentum arteriosum. So, to summarize these relations on the inferior aspect, you have a superficial cardiac plexus and the left recurrent laryngeal nerve, and in between you find the ligamentum arteriosum and the artery, the bifurcation of the pulmonary trunk and the left pulmonary artery. So, moving on to the superior relations. The branches of the arch of aorta itself form the superior relations along with a few other structures. So, we have the brachiocephalic trunk, the left common carotid artery and the left subclavian artery. So, these are nothing but the branches of the arch of aorta itself. They are extending superiorly, so they are mentioned as relations which to the arch superiorly. And you have the vein, that is the left brachiocephalic vein. So, in addition to this, you might find variable extent of the thymus gland. So, depending on how much of the thymus extends onto the superior mediasternum, you will have a variable relation of this particular organ to the arch of aorta. In addition to this, you can also come across the crossing over of the left vagus and the phrenic nerve between these two particular arteries, that is the common carotid and the left subclavian, which can be seen in dissection. Okay. So, these are the superior relations. To mention a few, that is the three branches, the left brachiocephalic vein and variable extent of the thymus, and the crossing over of the phrenic and the left vagus, which of course cannot be seen in the picture. So, this is about the relations. So, what is the importance of having these relations? So, this is a cross sectional view where you can see the arch of aorta and the nerves. So, this is the left side and the right side. You are visualizing this picture as if you are seeing from the foot end of the person. So, this is your left phrenic, this is your left vagus, this is your right phrenic, this is the right vagus, and the nerve here is the left recurrent laryngeal nerve. The two tubes here are the trachea, the esophagus, and you have the thoracic duct here. You have the veins here, that is a brachiocephalic and the superior intercostal vein, which is nothing but the tributary of the left brachiocephalic vein, and you have variable extent of the thymus. So, any of these structures can get compressed if there is any pathology related to the arch of aorta. So, if it compresses on the nerves, then you can have hoarseness of voice when it compresses on the recurrent laryngeal nerve. You can have some pathology in the diaphragm if the phrenic nerve is compressed, so on. So, similarly, if it compresses on the veins, then there can be venous engorgement and bloating of the face. So, if it compresses on the trachea, it can result in dyspnea, and esophagus, it can result in dysphagia. So, all these clinical symptoms due to compression of these structures tells us the importance of these relations to the arch of aorta. So, next we will move on to the branches of the arch of aorta. So, the first and foremost branch is the brachiocephalic trunk. So, this is the biggest branch, most anteriorly placed, and it is the first branch. So, this branch, it arises from the anterior aspect of the arch, ascends upwards and to the right, and then it reaches the right sternoclavicular joint, and here it divides into the right common carotid and the right subclavian. The right common carotid will supply the right half of the head and neck, and the right subclavian will supply the right upper limb. Next, the branch is the left common carotid. So, this particular branch arises a little posterior to the brachiocephalic trunk. It ascends along the left side of the esophagus and trachea and supply the left side of the head and neck region. The third branch is the left subclavian artery. So, this again follows the same course as the left subclavian artery, ascends upwards along the left side, and it will supply the left upper limb. So, if we see this in a cross section, we can see the three branches which are being shown in darkened colors. So, the first one will indicate the brachiocephalic trunk, the next one will suggest the left common carotid, and the last one is the left subclavian artery. So, these are the three primary branches of the arch of aorta, but we come across innumerable variations in the branching pattern of the arch of aorta. So, this is the first and foremost clinical branching pattern. Here we see the left common carotid which arises from the brachiocephalic trunk instead of the arch of aorta. So, this also shows the same thing. One is a proximal attachment and the other is the distal attachment of the left common carotid from the brachiocephalic trunk. So, there are two branches here from the arch of aorta. Here this picture shows a increase in the number of branches. So, in addition to the three branches, we have an extra branch which is usually located between these two arteries, that is the left common carotid and the left subclavian, or it can be anywhere elsewhere, but this is the usual place where you find the extra branch. And here you see the reduction of branches where you see two brachiocephalic trunks which subdivide into right and left common carotids and the subclavian arteries. Another common variation which we encounter is the origin of the subclavian artery. So, this is the subclavian artery. It arises at the junction of the arch of aorta and the descending thoracic aorta. So, if this happens, then it can compress on these tubes. So, the trachea, the esophagus, causing dyspnea and dysphagia. So, this is the right subclavian artery. So, these are the usual branches, extra branches which can be arising as direct branches of the arch of aorta. One is the thyroideema artery, the inferior thyroid artery, the left vertebral artery, the internal thoracic artery, the left bronchial artery, and of course, this right subclavian artery present at the junction of the arch of aorta and descending thoracic aorta. So, these can arise directly from the arch of aorta and they are extra branches. So, these are the number of variations which we come across. Moving on to the development of the arch of aorta, it develops from four sources. The first segment is the aortic sac, which is the distal part of the truncus arteriosus. The next segment includes the left horn of the aortic sac. The green segment shows the left fourth aortic arch. So, the pharyngeal, the fourth pharyngeal arch contributes to the connection between the dorsal aorta and the left horn of the aortic sac. And the last segment is the dorsal aorta itself on the left side and the 7th intersegmental artery. So, all these 4 units contribute to the complete formation of the arch of aorta. And we also see that in fetal life there is a connection between the left pulmonary artery and the arch, which gets fibrosed at birth and forms the ligamentum arteriosum. If it is not fibrosed, if there is a connection still existing, then there can be mixing of oxygenated and deoxygenated blood in adult life also, and this condition is referred to as patent ductus arteriosus. So, what are the other anomalies we come across, that is congenital anomalies? So, the commonest is the coarctation of aorta. So, coarctation is nothing but narrowing of a segment of the aorta. So, this can happen anywhere along the aorta, more often close to the arch. And in relation to the ligamentum arteriosum, we can classify it as preductal and postductal. So, in preductal it is behind the ligamentum arteriosum, whereas in the postductal state it is beyond the attachment of the ligamentum arteriosum. And in both cases there is a difference of blood pressure between the upper limb and lower limb. Reason being, the amount of blood which flows down is reduced. So, you find a difference in blood pressure. So, that was about the coarctation of aorta. And the next clinical anomaly associated with development we have already mentioned is the PDA, that is the patent ductus arteriosus, where the connection persists in adult life between the left pulmonary artery and the arch, and there is ample amount of mixing between the oxygenated and deoxygenated bloods. Another interesting anomaly we come across is the double aortic arch. Now, this is not a common entity in mammals, however, it is very frequently seen in lower animals like the frogs and other reptiles. So, here both the horns of the aortic sac get connected to the dorsal aorta and both develop individually. So, there are 2 aortic arches present. So, that is about the double aortic arch. And lastly, we have the right aortic arch. So, instead of the left becoming prominent, you have the right horn developing and getting connected to the right dorsal aorta. So, we have a right sided arch. So, this is usually associated with situs inversus, where all the left sided organs may be shifted to the right. So, this is a usual anomaly which is associated with that. A little bit about the structure. Now, the aorta as such is an elastic artery with a huge elastic component in its layers. So, we usually find the 3 usual layers which are seen in any artery, that is the tunica intima, tunica media and tunica adventitia. And the striking feature here is the presence of the elastic fibers in tunica media. The entire tunica media is filled with these elastic fibers, and thus we are not able to visualize the internal elastic lamina which we often see in the muscular arteries. So, what is the importance of this structure of the arch of aorta? So, whenever any layer of the aorta thins out, especially the tunica media, what happens is, due to the internal pressure of the blood, that segment of the vessel will get dilated and it will appear bloated out. So, this condition is referred to as aneurysm of the aorta. So, here you can see the bulging out of the segment of the vessel wall. So, that is nothing but the aortic aneurysm. Now, if there is prolonged aneurysm, then what happens is the pressure of the blood will cause the blood to insinuate between these layers. So, this is called as dissecting aneurysm, and if it is left untreated, it can rupture, there will be mass hemorrhage and it can be fatal. So, the person can immediately collapse and die. So, this was about the structure. So, what we are seeing here is the aortic aneurysm. So, what are the things which we studied in today's session? We looked at the location, that is behind the manubrium sternum, lower half. The arch, it courses posteriorly, superiorly to the left, and then finally inferiorly. The important relations it bears with the nerves, that is the phrenic, the left vagus, and also the cardiac branches, and the veins and the viscera, which form an intimate relation, also the trachea. So, when we were talking about the Oliver's sign, we found the relation. It is related, the trachea as it comes down, the arch is related anteriorly to the trachea, and then the bifurcation comes below. So, whenever there is ventricular contraction, if there is an aneurysm which is present, it will pull the trachea down. So, that is the importance of the relation and the correlation of the Oliver's sign to the anatomical relations of the trachea and the arch of aorta. The branches include the three branches, it's a brachiocephalic trunk, the left common carotid and the subclavian, and we also saw the number of clinical variations which were seen. The development, it's mainly from the distal segment of the truncus arteriosus and its connection through the pharyngeal arch, that's the fourth pharyngeal arch to the dorsal aorta, and the structure we saw it as the elastic artery. So, these were the clinical anatomy points which we discussed. So, here in this picture you can see a little prominent aortic knuckle compared to the previous X-ray, which might be due to some pathology of the arch of aorta. So, based on its location, we can determine the location of the arch of aorta in X-rays, and we also spoke about the aortic knuckle, the aortic windows, and how it is seen in the CTs and MRIs. We also discussed about the surgical approach, the variation in the branching pattern of the arch of aorta, the congenital anomalies associated with the arch of aorta, and also the anatomical basis of the development of aortic aneurysm. So, with that we come to the end of this session, and I am really thankful to the NPTEL Swayamprabha team and Dr. Vijay Sagar sir, and I also extend my thanks to the KIMS radiology department for sourcing me with the relevant X-rays. So, let's end the session with a nice quote: always be curious but never judgmental. So, with that, have a nice day. Thank you.